Hello, everyone. So welcome to week 6 and our second and final week of covering psilocybin. So I know that this is titled Spirituality. That was covered quite thoroughly in the video that you watched this week. So I'll be covering the readings, which are focused more on addiction. All right. So the chapter that we read this week was psychedelics in the treatment of addiction, specifically psilocybin. So quick refresher here, original psychedelic research from the 50s through the 70s focused on treating addiction, specifically alcoholism, where LSD was used, lysergic acid, dithylamide, and classic psychedelics like mescaline and dipropyltryptamine were also explored in using alcohol for alcohol treatment. The initial hypothesis was that psychedelics could mimic delirium tremens, promoting sobriety. So delirium tremens, in some hypothesized in some way of like rock bottom, could propel somebody out of use. And instead of dysphoric reactions, researchers observed positive and insightful effects promoting sobriety. So not necessarily getting there through like terrifying the person or mimicking a rock bottom, that there was some insight that could happen. So hopefully this is some level of review for you at this point. So studies investigating LSD and alcoholism treatment show varied methods and initial conclusions. Some studies reported positive trends without statistical significance at small sample sizes. Previous research or reviews concluded that the efficacy of LSD in treating alcoholism was undetermined. There was a meta-analysis of older studies, again in the 50s and 60s, that randomly assigned patients to LSD or a control, which showed significant decreases in alcohol misuse through LSD treatment. And then some more recent open label pilot studies using psilocybin and alcohol use disorder have shown promising results. So I think in some ways this is an indicator, not necessarily of the difference between LSD and psilocybin, but I think us understanding the process a little bit better. So set and setting, for example, were not priorities in research in the 50s and 60s in clinical research. And I think we're just learning a little bit more about the human aspect of this. And I also think we're understanding a little bit better the dose aspect of this. Early research suggested that treatment outcomes depend on the nature of the subjective experience following psychedelic administration. So that integration piece, also some of that, the qualitative data that really wasn't there in the essentially first wave of psychedelic research. And this suggests a paradigm shift in the treatment model for alcoholism using psychedelics. So I think, again, previously the thought was that in some ways the substance did like all of the work. And then we as in the guides, facilitators, the people, professionals who were there in the room with the person didn't really matter. And we're really finding that that is not the case. So unlike typical addiction medications, the efficacy of psychedelics may not rely on directly modifying neurobiological alcohol effects. So this is, I think, really key. And in some ways, part of the myth of psychedelics is that it's this like silver bullet, it's this magical cure, that it's this one-time thing and you have learned everything that you can about yourself, and whatever ailments you are struggling with, they are cured. And that just, it's not. Some research even hypothesized that the psychedelic really has not much at all to do with this. So again, still like kind of playing with some theories about, why are these outcomes quite a bit more effective, or at least at this time efficacious as any existing treatments that we have for things like anxiety, depression, addiction, PTSD. Why are psychedelics different? Psychedelics may induce powerful plastic states, which we learned about in terms of malleability in some ways of the brain, promoting heightened learning and persistent behavioral change. So that top-down hierarchy really is leveled out, and there's expansion in the brain in terms of different pathways being taken. Single or few administrations of psychedelics can lead to lasting reductions in depression and anxiety, contrasting the daily administration of traditional psychiatric medications, which is really powerful. And in many ways, that is a complete paradigm shift from the way that we do treat diagnoses like anxiety and depression, because that is a daily administration. Particularly with psilocybin. Psilocybin is one of the longest lasting in terms of like when you take the substance, you're feeling the effects of that, not necessarily like the, your tripping effects, but some of the like insights, the positive effects, when you come back to sobriety after the session of positive things happening in terms of things with neural pathways and your outlook and perspective, which is absolutely in some ways antithetical to depression and anxiety medications. So one of the cool things about this is in some ways addiction might be closer in theoretically, conceptually, functionally to other diagnoses like depression and anxiety. So particularly with the application of psychedelics. So basically what the author here, Dr. Johnson, is saying is that maybe psychedelic therapy, yes, we're like testing it on for all these different indications, right? And the indication means a diagnosis, psilocybin for the treatment of alcohol use disorder, psilocybin for the treatment of generalized anxiety. But there might be, in terms of like neural pathways or the ways in which psychedelics treats that, there may be generalities. So I really appreciate how Dr. Johnson talked about how in some ways there's we talk about like crossover addictions, but in some ways I think he's talking about like a crossover diagnosis where really biologically or perceptually, how different is depression than addiction? And feel free to respond to that and say, from firsthand experience, it's categorically different. Feel free. But he's really just trying to say, I think perhaps these diagnoses and the ways that this affects the brain chemistry and the pathways and the way if it affects the individual in terms of behaviorally, maybe there's more similarities than there are differences here. So I'm wondering if this application could be similar. So psychedelic therapy paradigm offers generality beyond alcohol use disorders. The enhanced potential for learning and plasticity may extend to other substance use disorders and behavioral change in general. So again, what is some behavioral change in terms of the treatment of and moving through a diagnosis like anxiety or like depression? This paradigm distinguishes itself from the typical model of psychiatric medications. Like I said, this is like a one-time, we're testing up to 3 times of a dose over the course of, let's say 6 months, as opposed to a daily medication in many ways, like for the rest of one's life that they are struggling with the diagnosis. Psychedelic therapy can bring about lasting behavioral changes with single or few administrations. Like I said, the potential for broad applicability and lasting effects makes psychedelics a promising avenue for addiction treatment and beyond. I agree. So psychedelics and clinical potential for substance use. Psychedelics have shown clinical potential for substances of abuse beyond alcohol. Psychedelics currently are being applied to every use disorder that's in the DSM-5 text revised, with the exception of hallucinogen use disorder, because largely people in this field don't agree that that's a thing. And it's extremely rare. Like even in the incidences that happen. Anyway, so I will argue that it's in some ways, I think I don't want to sound dismissing. I think in some ways it's just like an ill-informed inclusion in the DSM. Early research explored the therapeutic potential of LSD in treating opioid dependence, which is one that has largely, like I talked about last week, has been a little bit like hot to touch, very politically driven. It's extremely easy to overdose on opioids. So one of the fears is that when a participant is in a trial, that so for those of you who either haven't taken chemical dependency yet or unfamiliar, a person loses their tolerance for opioids very quickly upon any period of abstinence. And generally what happens with overdoses is if a person hasn't used opioids for a while, they tend to go back to the same dose that they were using previously, which now their body has virtually no tolerance for, and that's what leads to an overdose. So it's one of the most lethal in terms of dosing, and how quickly one can overdose substances that we know of. And one of the fears in that is that somebody will lapse maybe during a trial, which is not uncommon. And in some ways, because psychedelics are part of the harm reduction model, they lean more into the harm reduction model, that lapses are really seen as, in many ways, a beneficial experience, in some ways to like concretize somebody's desire to no longer use. With opioids, that lapse has a much higher likelihood of being deadly. So the fear is that somebody overdoses when they're in a trial, and then their overdose is said to be because of psychedelics. And then that would shut all of this down again. So there was a study conducted in 1973 involving 78 heroin-using individuals under parole probation supervision. Participants were randomly assigned to either an experimental or a control group, and the LSD group exhibited significantly lower heroin use, even at the 12-month post-treatment assessment. And post-treatment can either mean after the dose of psychedelics, or at the end of integration. I don't remember in this case if usually that time period is 2 to 3 months difference between substance administration or psychedelic administration and end of integration. So the study revealed participant comparisons of LSD effects on heroin effects. Heroin was described as numbing and distancing from oneself and surrounding, whereas LSD was reported to enhance this awareness and confront personal issues. So again, in many ways, psychedelics work so differently than other substances, where other substances are in many ways a way to escape, a way for respite, a way for some numbing, just like having the world kind of go away. And LSD does, and psychedelics do the exact opposite. So that's another reason why researchers in the field of psychedelics really don't agree with hallucinogen use disorder being in the DSM. Participants described heroin as a night-like experience, while LSD is compared to dawn, bringing new awakening. So these testimonies highlight the contrasting effects and potential of psychedelics in terms of addiction treatment. So just fundamentally different effects from any other substances that can be abused. So with this study, they the authors acknowledge limitations, including differences in other treatment aspects. So potentially some like allegiance type things where, you know, they tried a little bit harder. I don't know if it was a double blind. If it wasn't a double blind, that's a limitation in any sort of research, because if you know what you're trying to test, like if you know who's getting what you're trying to test, whether you want to admit it or not, you likely are being a little bit more, you're giving a little bit more effort, you know, you're trying a little bit harder with people in the experimental group that you're trying to prove that this thing works. Because usually people test things that they have allegiance to. Like I work with psychedelics because I believe in their potential. I'm not here really trying to prove that they don't work. I'm trying to be a scientist and see, you know, does this actually work with some neutrality? But to say that I'm not excited about it would be a lie. So if I knew who was getting the psilocybin, that potentially could affect the way that I work with the participants. So despite limitations, the preliminary data showed promising results. Unfortunately, there have been no follow-up studies conducted in the 45 years since this publication. As we learned last week, the University of Wisconsin-Madison they are the only site in the world that is studying opioid use disorder with the application of psilocybin-assisted therapy. So given the opioid epidemic, it is an opportune time to revisit psychedelics and their potential in treating opioid use disorders, which we are exploring. The use of psychedelics could offer new approaches to address the opioid crisis, which it would be wonderful. And we are learning as we're going along some of the, potential limitations of the medicalization. You know, how do we help psychedelics be accessible to individuals who really could benefit from it? Because like we've talked about, the individuals who are struggling with PTSD, anxiety, depression, addiction, don't necessarily have a ton of money to be able to pay for this in terms of private pay. So, you know, how do we as a field, how do we as in some ways like a globe, help really make this treatment accessible to individuals who really could benefit from it? So Dr. Johnson talked about his own research with tobacco, and we looked at an article of his also this week in much more detail. Tobacco addiction is a significant problem where it's characterized by drug-mediating reinforcement, craving, withdrawal, and high rates of relapse. Unlike other intoxicating drugs, tobacco addiction does not lead to substantial behavioral intoxication or immediate life destruction. It was dubbed like kind of a pure addiction. It also is the most deadly. More people die from tobacco every year than any other substance. So super risky. Psychedelics may have potential in treating addiction, allowing individuals to reevaluate their life situation and make positive changes. Tobacco addiction serves as an interesting test case due to its unique characteristics and widespread impact. As we know, there's some countries around the world where it is not uncommon for children to start using tobacco. It's very much engrossed or it's very much present in the culture. Smoking is responsible for more deaths than any other drug, highlighting its urgent need to figure out any ways that we might be able to help people not use it as much. So open label pilot study, again, that means that the individuals and the researchers know what the treatment is. And this was a non-control. So all 15 of the nicotine dependent individuals received psilocybin. They also were considered treatment resistant tobacco smokers. This usually means that they have a minimum of 3 failed attempts to quit, where they have like employed some level of like professional intervention. Participants had multiple previous quits and on average smoked 19 cigarettes a day. Also just thinking about, you know, the fiscal impact of that. I think 20 cigarettes come in a pack. I'm not sure. But packs of cigarettes are, I don't know, like between $8 and $10. Anybody who knows, let me know. But that's like legit cost for somebody too. So I could potentially see that as being another reason why people are wanting to maybe either reduce or stop using. The study included a 15-week program of CBT for smoking cessation and up to 3 psilocybin sessions. First session was in some ways like required, and then the 2 subsequent sessions were optional for the individuals, with increasing dosage. So it started at moderately high, 20 milligrams of psilocybin per 20 kilograms of how much the person weighed, up to what's considered a high dose, which is 30 milligrams per 70 kilograms. No serious adverse events related to psilocybin were reported during the study. And then in this pilot study at the 6-month post-target quit date, or TQD, 80% of participants were biologically verified as smoking abstinent. 60% of participants reported having a, quote, complete mystical experience. That was used utilizing the mystical experience questionnaire, MEQ, during their psilocybin sessions. Higher mystical type experience scores were associated with smoking abstinence and reduced cigarette cravings. So if you endorsed like a higher mystical experience, then it had like in some ways like an inverse relationship. The higher your score on the MEQ, the lower your rate of use. Or you could say it has they have equal association, where if the higher the mystical experience, the higher the likelihood of abstinence. Long-term follow-up interviews were conducted at 2.5 years, revealing lasting effects, including insights into self-identity, reasons for smoking, and increased pro-social behavior. Biologically confirmed abstinence rates were 67% and 60% at 12 and long-term follow-ups respectively. So 67% abstinence rate at 12 months, 60% abstinence rate at 2.5 years. So then they did a comparative efficacy trial, which is currently being conducted. Randomized participants to a single psilocybin session or transdermal nicotine patch in combination with a 13-week CBT program. fMRIs were used to assess cognitive control before and after target quit date. So they would take scans of the brain basically the day or two before the target quit date, which is also when they administered the psilocybin, and then no more than 2 days after the psilocybin session. Preliminary results show higher cocaine verified. So it's a product formed after the chemical nicotine enters the body. That's tested through blood or urine. I'm going to guess urine because it's less invasive. It's much easier to test urine than it is to test blood. 12-month abstinence rates in the psilocybin group compared to the nicotine patch group. So still 30% higher abstinence. Psilocybin participants demonstrated improved cognitive control and reduced MRI response in the superior parietal cortex after quitting. So let me tell you a little bit about the superior parietal cortex. Your brain's parietal lobe is a key part of your understanding of the world around you. It processes your sense of touch and assembles input from other senses into a form you can use. Your parietal lobe also helps you understand where you are in relation to others that your senses are picking up around you. Parietal lobe damage may limit your ability to process sensory information and create difficulty with spatial awareness. This can include deficits such as poor proprioception, impaired vision, speech difficulties, and even hemi-neglect, which is an unawareness or unresponsiveness to objects, people, or other stimuli. Sometimes patients even ignore or disown their own left limbs. Hemi-neglect is like on your left side, or I think it affects your right brain, so it affects your sense of your left side. So just giving you a little bit about, what is the role of the parietal cortex, the superior parietal cortex, and how it is, how it may be affected through psychedelics. Okay, so this is a study that I have been a part of. So with my mentor, Dr. Peter Hendricks at the University of Alabama at Birmingham. As I covered a little bit last week, so for cocaine use disorder, there's currently no FDA-approved medication for its treatment. So there is, I think we're at like, we need like less than a handful more participants. So this, just so y'all know, in terms of just like how difficult it can be to get participants, and possibly it's because it's, you know, in the deep South, who knows? There could be other reasons, I'm not sure, but recruitment started in June of 2015. So it started, recruitment started 8 years ago, and we're working on getting 40 individuals. And I think we're at like 37 or something like that. So they received a moderate high dose of 25 milligrams per kilogram of psilocybin. So it's double blind, meaning people are, and it's randomized, it's an RCT. So participants are randomly assigned to either a psilocybin or getting a high dose of diphenhydramine, I think like 100 milligrams. So like they got super sleepy. Preparatory meetings involved CBT content and specific preparation for a high dose, medium high dose psilocybin session to take place before drug administration. So they had 4 preparatory sessions. Each session is 2 hours long. First hour was really focusing on the manual, making sure that everybody, there was fidelity and everybody at the minimum received like that same part. And we took the second hour to like really cater the conversation to anything they wanted to talk about. And in many ways, just like build trust with our participants. And then so there were 4 sessions, 2 hours each. On the 4 sessions when we covered really in detail, what are some things you can expect from the psilocybin session. And then we also employ fMRIs to explore potential neurobiological correlates of treatment success and psilocybin efficacy for cocaine abstinence. So let me show you what the outline of this study looks like. So we have people who call and say like, hey, I'm interested. And if they meet criteria from the phone screening, we invite them in. We do a baseline assessment, which includes things like a 90-day, like they record their past 90 days in use and like their frequency, amount of use, all of that. Relatively difficult to do, but we have like study assistants who really take their time with the participants to talk to them about that. And then we also have them do several questionnaires. We have 2 pre-screen appointments for them that really are just can you get here? Can you make an appointment and be consistent? So we actually lost quite a bit of possible participants at this point. Just super difficult to keep an appointment. Many people didn't have transportation. You know, cocaine can be a little bit of a chaotic life in terms of your like awareness of time sometimes. So just participants would have like, for example, an appointment on Tuesday. They'd call on like Friday that week and be like, I have an appointment today, right? And it's like, nope, you have one on Tuesday. So just you know, to be on a regimen when many of these individuals are not employed, many of them are unhoused, you know, time is it's just a construct in some ways. And they had a medical exam with our study physician. So they were paid for each of those pre-screen appointments, 1 and 2, as well as the medical exam. And then if they like cleared all of that, then they would start sessions with myself and my mentor. So weeks 1 through 4, we do preparation sessions. And then about 2 days after preparation 4, so that final preparation, they get their first MRI, an fMRI screening of their brain. And then about 5 days after MRI 1, because in between there is the drug administration. So about 1 to 2 days before drug administration, they get their first MRI. Preferably no more than 1 day after drug administration, they get their second MRI. And so the drug administration, like I said, 25 milligrams per 8 kilograms. And they spent 8 hours on our campus. It's called the Clinical Research Unit. And then the day after their drug administration, they got MRI, their second MRI. So in between MRI 1 and the drug administration was hopefully no more than a week. And then hopefully the next day after drug administration, they got their second MRI, and then they started their integration sessions, which is weeks 5 through 8. So they had 4 2-hour sessions with us, just kind of talking about any insights that they gleaned, what can we do with them. And one of the things that we found was that the substance was really not talked about anymore. So we did that for 4 weeks. So they essentially were in treatment for 8 weeks. And then we did a 90-day follow-up after EOT, means end of treatment. And then they only did an assessment with that. And then we did another follow-up 180 days where we gave them essentially the battery of quantitative, like surveys, questionnaires, and then we did some qualitative interviews with them as well. But just wanting to let you know, so this is a 9-month period, and they were paid at every assessment. So baseline assessment, pre-screens, the medical exam, both MRIs, and the 90-day and 180-day assessments, they were not monetarily reimbursed for any of the treatment that was provided by myself and Dr. Hendricks. And I believe that over the 9 months, we did try to, like, thank them for their time, but we didn't want people coming in just for the money, because that happens a lot, particularly in cities where there's a really prominent university, where sometimes people in some ways make a living off of participating in research. And this was one that we really, again, we wanted it to be fair, but not coercive. So I think they were paid upwards of $180 over a 9-month period. So that's not worth it. So we really wanted people who were really wanting to quit. Okay, so preliminary results. What we did was we unblinded the first 10 participants. And for anybody who's interested, if you Google or if you search my name on YouTube, you will find our talk at Horizons conference in New York City, I think in 2018. So promising safety and potential efficacy for cocaine abstinence observed in the psilocybin group, no serious adverse effects. The psilocybin group, after that unblinding, so unblinding the first 10 participants, they had a mean of 100% cocaine abstinent days during the final 90 and 100-day assessment, compared to about 86 in the control group, which is considered a statistically significant difference. And then urinalysis, we gave them every single time they were in the office, they were given a urinalysis. This confirmed abstinence in the several days preceding the 180-day follow-up visits. We would do that when they came in, and 180-day follow-up. In some ways, it was around 180 days because we just really wanted to work with their schedule. And if they couldn't come in right on 180 days, that's okay. We did try to get them at a minimum 180 days. If it was 183 days or 4 days, that's okay. Okay, so some additional findings. The psilocybin group showed substantial increases in life satisfaction at each follow-up compared to the control group. So again, through surveys, through qualitative research, the psilocybin group reported reduced stress at most follow-up visits. The psilocybin group had statistically higher ratings on all factors of mystical type experience, including unity, positive mood, transcendence of time and space, and ineffability, which we talked about are some of the constructs that are I'm going to sneeze. Excuse me. That are measured with the MEQ. The psilocybin group had higher ratings in all factors of challenging experiences like grief, fear, and physical distress. So, they were either on psilocybin or sleeping. So that both of those make sense. Session experiences appeared to align with expectations for high-dose psilocybin administration in the psychedelic therapy context. So in terms of what to expect in this session, so then there's continued promising results may address the unmet need for effective medication treatment for CUD. So cross-addiction generality and potential research direction. Psilocybin therapy shows promise in treating tobacco and cocaine use disorders, suggesting potential cross-addiction generality, just meaning that it can be applied to hopefully any type of addiction. This also means not just substance addiction, things like gambling, which really is the only process addiction that we have in the DSM. Revisiting the use of psychedelics in treating opioid use disorder is necessary given the opioid epidemic. Exploring the treatment of other target drugs of abuse, such as methamphetamine, could be valuable. I believe that they're doing a trial for methamphetamine at like the University of New Mexico, somewhere in the Southwest. Anti-addiction effects may extend beyond drugs of abuse to other conditions, like I said, depression and anxiety, and broadening the scope of psychedelics as behavior change agents may lead to a paradigm shift in psychiatry. So we'll see. And then expanding the scope here. Considerations should be given to testing the efficacy of psychedelic therapy in treating disorders beyond addiction, including anorexia, which I believe there is research being done at UCSD on that. Obesity, I'm not aware of. Gambling disorder, I don't think that that has been started yet. And then sexual impulse control disorders, very interesting work. And, you know, if you think about, again, the behavioral aspect of all of these diagnoses, that, you know, there really could be some benefit to testing. Empirical testing is needed for each disorder, along with future research on psychological and biological mechanisms. Again, we're not quite sure what it is. Is it a combination? Can we isolate? You know, what is it? How do we help people who are struggling with different diagnoses? The abilities of psychedelics to temporarily allow individuals to see outside narrow pathways. So again, the leveling of the brain and its connectivity, and adopt more optimal patterns of living, maybe broad applications. Increased resources, qualified scientists, and federal funding are necessary to fully explore the potential. And the field of psychedelic research should expand to encompass a diverse range of disorders and attract the necessary support for comprehensive testing. So almost all of, at this point, yeah, I would actually say all of the research being done with psychedelics is privately funded. So, I mean, there are people with money who are interested in this stuff. So, okay, then we're going to get to the article, Dr. Johnson's article, talking more in depth about what was covered in the chapter. So, patient experiences. So this was with alcohol use disorder. So during the psilocybin-assisted treatment, they're highly variable with diverse themes and outcomes. So these experiences, as we read some of the qualitative results with this, super different qualitative experiences. They range from classic mystical or peak psychedelic experiences to feelings of forgiveness, self-compassion, love, catharsis, acceptance. The content of the medication session is uniquely relevant to each individual, supporting their recovery efforts, which I just think is so beautiful. Like, that's exactly what happened in our study, where no two experiences are the same. And just the hope is that they've encountered something in that experience that was meaningful for them, and that like really helped move them toward their goal of reducing use or abstaining. Participants achieve reduction in alcohol intake regardless of their initial drinking profiles, reflecting their personal goals. So in this study, everybody reduced. Medication experiences may present the issue of drinking within a larger psychological or spiritual context. So that's another thing to keep in mind with psychedelics in terms of like PAP, is that very few of, like in the qualitative research, very few of the participants' experiences actually have like substance specific content in their experience, which I just, you know, it's because in many ways, I think they're so much more complex than that. So they don't have to have any sort of substance specific visions, content in their experience for it to be helpful for them. So positive changes in mediators of change. Participants reported marked changes in self-perception, daily consciousness, increased self-efficacy, decreased craving, alcohol-associated problems, anxiety, and depression. So just so you can see, all of that's wrapped up in the addiction. It's not just about use, it's all kinds of stuff that can contribute to somebody's use. So and that's a beautiful thing about psychedelics, is it kind of touches on all of that. Trajectories of change in anxiety, depression, and self-efficacy may differ among participants, as we saw yeah, it's not a plot, the line graph in that, those are all different. Lack of coherent verbalized narrative does not diminish the meaningfulness or positive impact of the experience. Ineffability is not a limitation. It's a thing. It's just a thing. Mediators of change range from psychological to mystical, including self-compassion, love, connection, catharsis, psychodynamic material, and mystical content. So again, we're still kind of putting our finger on what might be helpful, but in some ways, I don't know that, I think for every person, it's kind of a moving target. Individual experiences facilitate personal growth and support the therapeutic approach of finding personal meaning in the experience. So again, that's another reason why we took in our study that second hour with the person to better understand them. So then when they had their mystical experience, then when they were sharing with us, it made some sense to us because we had been getting to know them. So it wasn't so in some ways it wasn't a surprise to us of some of the content that our participants experienced or encountered. So personalization and future research, this is a theme in terms of our readings, is observations suggest that personalization and diversity of experiences are important in facilitating positive outcomes. Personalization, we did that in ours, again, by that second hour of just, we personalize that treatment to every participant because they're a human. And this personalization also, we've talked about that in terms of the music. And some suggestions from participants of I would like for the music to be specific to me. The therapeutic approach used in this study encourages participants to find personal meaning in their unique experiences. Empirical evidence is yet to support the superiority of this approach over others in terms of the this personalization. Controlled trials are needed to determine the effectiveness of the model for treating AUD, and then future research is required to identify the most effective therapeutic approaches and understanding their mechanisms of action. So, what theories are we using? What other general approaches, frameworks are we using? And does that affect outcomes in any way? So the last article that we read this week was Psychedelic Therapy for Smoking Cessation, a qualitative analysis of participant accounts. So here were all of the themes in blue and sub-themes under them. So they had psilocybin-related factors contributing to their smoking cessation, such as insight into self-identity, insights into smoking behavior, experiences of interconnectedness, sustained feelings of awe and curiosity. Awe is a really unique characteristic of a psychedelic experience. It also can be experienced when you're out in nature, or when you're standing next to the redwoods and you're in awe at how big these things are. Reduced withdrawal and cravings. And then there were non-psilocybin factors contributed to smoking cessation, like the preparatory counseling, the rapport built with the study team, momentum, meaning that if they had a period of abstinence prior to the psilocybin session, that they just kind of kept going with it. In momentum in terms of not using. So they already had, 7 days without use, let's just keep rolling with this. And then therapeutic intent. So what they wanted to get out of being a part of the study period. Reflections on the research protocol. So psilocybin session music, many of them said, I loved it. Others said, I would like it to have been personalized to me. Meaning making across sessions. And then the effects beyond smoking. So aesthetic appreciation and altruism and pro-social effects. So again, that just speaks to a person is more than their use. And that really becomes highlighted after the psilocybin session. So mechanisms of change in the session or in psilocybin facilitated smoking cessation, participants reported powerful insights into self-identity and smoking behaviors during the psilocybin experience, leading to a diminished desire to smoke. Experiences of interconnectedness, awe, curiosity, and positive affect persisted beyond acute drug action, reducing withdrawal symptoms and craving to smoke. So that's a huge thing. A lot of people continue to use because withdrawal sucks. It's painful, it's distressing. So I'm just going to put the substance back in my body to stop this feeling. Non-drug mechanisms such as preparatory CBT helped participants become aware of their smoking habits and explore motivations to smoke. So that's where the manualized portion of this, it is very CBT driven. It is very use driven, helping the person become a little bit more aware of why they use, what the benefits are, what some of the drawbacks are, what are some of the triggers. So very common, what would be encountered anywhere in terms of outpatient substance use treatment. Preparatory counseling built rapport and trust with session guides, contributing to a sense of safety during the psilocybin sessions and ultimately aiding smoking cessation. Thought it was kind of cool that some of the participants were like, I was contemplating using, and then I thought of the guides. And we had built, like, I felt a closeness to them and I didn't want to let them down. Like, I'll take that as a person wanting people to reach their goals. If I'm a part of that, very consciously in their mind, cool. The treatment design included an 8 to 10 hour period of smoking abstinence during the first psilocybin session, which created initial momentum toward long-term abstinence. So that's what they meant by momentum. I've already not used for a while. So let's keep this going. Psilocybin facilitated treatment elicited insights into self-identity and smoking behavior, making smoking less appealing or congruent with the person's previous senses of self. We've talked about that in others presentations about, Gestalt and IFS in terms of congruency. That's a big driving reason for people's distress. Psychological insights in the study represent epistemic potential for psilocybin experiences within a structured therapeutic intervention. So we are still figuring out the structure of all of this. And realizing that structure is pretty helpful. Persisting feelings of interconnectedness, awe, and curiosity were directly linked to smoking cessation outcomes. Pretty cool. Like, interconnectedness meaning not only my connection to other human beings, but like connection to the world and potentially universe at large. Awe is like a sense of a small self, a sense of oneness, and curiosity, just, I think in some ways being more open to different perspectives, different experiences. The mystical type experience, characterized by unity, interconnectedness, sacredness, positive mood, and transcendence, was reported by participants. So that's what a mystical experience is. Participants reported that feelings of interconnectedness overshadowed prior connections to smoking and extended to relationships in the world at large. One of the narratives that kind of hit me was the participant that said, like, I realized cigarettes were my friend, and that was like kind of sad. So I think in some ways that can be transferred into people, like friendships with people that can be more meaningful than with a substance. Mechanisms of change. Psilocybin sessions resulted in consistently less frequent and intense withdrawal symptoms compared to participants' previous quit attempts. Reduced withdrawal symptoms were directly attributed to the psilocybin experience, supporting the prior hypothesis that psilocybin can help with the withdrawal, which again lowers the tendency for use because they are not contending with this very, the very negative experience of withdrawal. Contemplation of psilocybin session experiences and gained insights may contribute to diminished withdrawal symptoms. So maybe they're just like not really thinking about or as aware of any withdrawal symptoms because they're like busy kind of contemplating. Rapport and trust with session guides allowed participants to delve deeper into their psilocybin experiences, fostering therapeutic benefit, because participants are like, I trust that they got me. That I think makes people more brave and courageous in terms of going toward things that are scary, because they know that they have two people in that room that they really intimately trust and they really believe like has their back. And that's huge. Momentum toward abstinence was observed from the target quit date onward, suggesting the importance of supervised abstinence periods. And last but not least, some integration, challenging experiences, and lasting therapeutic effects. Psilocybin session content and meaningful experiences across sessions are significant factors in smoking cessation outcomes. And so again, it's not just the psilocybin session, it's insights throughout the entire treatment period, which is about 8 weeks. Challenging experiences, although difficult, were associated with subsequent positive outcomes when supported by focused personal practices and skillful integration. So yeah, that stuff can be scary. But then when you have somebody who's willing to explore it with you, tell me what happened, let's delve into this, then you can see some of the insights that maybe are overshadowed by some of the fear. Aftercare measures such as regular communication with study guides, developing session narratives, and in-person integration meetings proved valuable. So these are things that happened after the psilocybin session that were shown to be really helpful, parts of the study, and in many ways part of the treatment. Multiple psilocybin sessions with ascending doses, getting higher, may be more effective than a single session for achieving lasting therapeutic effects. We're still testing this. Again, studies do anything between 1 and 4 doses. Psilocybin experiences were linked to persisting positive effects beyond smoking cessation, including increased openness, altruism, and pro-social behavior. Again, many of the reasons why people use in the first place.